Yeah, today we are going to discuss the management of the trauma. So here first we have to check the scene safety and check the response. If patient is not responding, call for help and talk to the patient for assessing the to check the airway. If patient is talking, uh, place the oxygen mask and C collar and proceed for the B, that is breathing. And if patient is not talking, if any features are present, that is tachypnea, which is an LUS feature, and use of the accessory muscles of respiration, or snoring, goggling, stridor, hoarseness, and cyanosis is the late feature. If any of these features are present, there is a problem in the airway, so remove the any foreign body if present, or bleeding, or the vomiting if present. Secure the airway. Even after the securing the airway, if the signs still persist, give MILS, that is manual inline stabilization, uh, to secure the cervical spine. And second, give the jaw thrust and chin lift. 2 members are required for the jaw thrust and also the chin lift. This procedure is helpful to maintain the airway. So when the help arrives, apply the oxygen mask and free the MILS giving person by replacing with the C collar, Philadelphia C collar. So after placing the C collar, so check whether the definitive airway is necessary or not. So if how we assess based on the apnea, if patient is having the apnea or GCS is less than or equal to 8 and SpO2 is less than 85%, so if any of these things are present, there is a need for the definitive airway. So if these things are absent, just give the oropharyngeal airway and proceed for the breathing. So if these apnea or GCS less than or equal to 8 or SpO2 less than 85% if present, go for the definitive airway. So we have to place the inline orotracheal intubation under the video laryngoscope. For this, 3 persons are needed, one for MILS and second for intubation and third for the burp. If inline orotracheal intubation if fails, try the second attempt. It is also fails, do the surgery. Surgery is the cricothyrotomy need to be done. And next, order of priority. First we have to check the airway, and next the cervical C spine. Next maintain the airway. Next step is the breathing. So after securing the airway and maintenance of airway, we have to go for the breathing. So in the breathing, we have to check for the tension pneumothorax or the massive hemothorax is present or not. We have simple pneumothorax, tension pneumothorax, massive hemothorax, and simple hemothorax. In simple pneumothorax, the patient respiratory distress is present, tachypnea is present, BP is normal, JVP is normal, and percussion note will be tympanic or the hyperresonant, and breathing sounds are reduced or absent. Absent is rare in the simple pneumothorax, and tracheal shift is normal or shifted rarely in the simple pneumothorax. So if patient is having this all the features of the simple pneumothorax, we have to observe the patient and proceed for the circulation and then do the secondary survey. In secondary survey, we have to do the chest x-ray. After chest x-ray, simple pneumothorax is confirmed, then place the chest tube. Next, scenario of tension pneumothorax, the patient may comes with severe respiratory distress and BP and JVP are elevated. BP is reduced and JVP is elevated, prominent neck veins are present, and tympanic or hyperresonant percussion notes, and absent or the reduced breath sounds, and trachea is shifted. So if patient presents with this profile, we have to proceed. Next step is the needle decompression or the needle thoracostomy need to be done. Needle decompression is done with the 14 gauge needle, which is 8 cm length over the sheath. In the pediatric patient, we have to place it in the second intercostal space. in the mid-clavicular line. In the adults, it should be placed in the 5th intercostal space in the mid-axillary line. And if patient is improved, go for the definitive treatment, that is tube thoracostomy or the chest tube placement in the 5th intercostal space in the mid-axillary line in both pediatric and adult age group. If a patient is of adult who are obese, and if the fails to improve, do the finger thoracostomy. If patient is improved, go for the tube thoracostomy or the chest tube placement. Next profile, that is massive hemothorax. So massive hemothorax, the patient presents with the severe respiratory distress and fall in BP, and JVP will be of not prominent, and dull percussion notes, and reduced breath sounds, and trachea shaft is absent. Trachea is in normal position. So in this situation is known as a massive hemothorax. That is, a patient will have this main important thing is a percussion note. So percussion note helps to differentiate between the hemothorax and pneumothorax. If a percussion note is a hyperresonant or tympanic, it is a pneumothorax. If it is dull, then it is a hemothorax. So after the presentation of this massive hemothorax, we have to go for the definitive treatment, that is chest tube placements or the tube thoracostomy. Next, simple hemothorax. In simple hemothorax, patient may present with a mild RD is present, and BP and JVP are normal, and dull percussion notes, and breathing sounds are reduced, and trachea shift is absent. Simple hemothorax, this suggests that patient is in with simple hemothorax. Go for the secondary survey. In secondary survey, we have to do the chest x-ray. After that, we have to place the chest tube or the tube thoracostomy need to be done. Next, open pneumothorax. In the open pneumothorax, which is also known as suckling chest wall, because why it is also known as suckling chest wall, because the skin, muscles or everything will be avulsed, and we can see the lungs which can be pulled inward and outward. So in this situation, we have to apply the close the opening on the 3 sides with the adhesive tapes and leaving the one side open. After placing the chest tube, close the 4th side. Why we are not closing all the sides? In order to prevent the tension pneumothorax. Next condition, it is a simple pneumothorax. If it is a simple pneumothorax, if the patient need ventilator, do not place the ventilator directly, because it may lead to the tension pneumothorax. In order to prevent that, we have to firstly place the chest tube, then put the patient on the ventilator. So the chest tube is placed in the triangle of safety, which is anteriorly bounded by the anterior axillary floor, posterior boundary is the posterior axillary floor, and base is by the 5th intercostal space. And after securing the breathing, then next step, it is the circulation. In the circulation, most common it is a hemorrhagic or the hypovolemic shock is the more common in the circulation. So hemorrhagic shock and non-hemorrhagic shock. If you look for the non-hemorrhagic shocks, first thing, it is a neurogenic shock. In the neurogenic, how to know whether it is a neurogenic shock? We have these features like hypotension, bradycardia, and also the warm extremities. So in this situation, we have to give the IV fluids plus vasopressors and also the steroids. And second condition, it is a cardiac tamponade. So how to know patient is in cardiac tamponade? We have this Beck's triad, that is hypotension, raise the JVP, and muffled and also the silent heart sounds are present. In the cardiac if this suggests that it is a cardiac tamponade. If the cardiac tamponade is due to the blunt trauma, first we have to do the pericardiocentesis, which is a temporary procedure, then do the definitive treatment, that is pericardotomy. So in the pericardiocentesis, we put the needle in the pericardial space and aspirate the blood. So it is done under the guidance of the echo. If echo is absent, then under the guidance of fast. If fast is also absent, that done under the guidance of the ECG. So this is how we manage the cardiac tamponade under the blunt, if it is due to the blunt trauma. So definitive treatment pericardotomy is done by left anterolateral thoracotomy. Next, if cardiac tamponade is due to the penetrating trauma, we have to do directly the pericardotomy, not the pericardiocentesis. Why we are not doing the pericardiocentesis in the penetrating trauma? Because the blood may be clotted in the penetrating injury, and if we place the needle and try to aspirate, we can't get the blood, so a patient may not improve it. So in order to prevent that, we have to do directly pericardotomy, which is a anterolateral thoracotomy or the subxiphod window. Next, hemorrhagic shock. So in the hemorrhagic shock, we have the classifications, that is class 1, class 2, class 3, class 4. Class 1, it is a compensated hemorrhagic shock. Class 2 is mild shock. Class 3 is moderate, and class 4 is severe shock. So in the class 1, if you see the class 1, the blood loss is of less than 15%, that is less than 750 ml blood loss is present. In the mild shock, it is 15 to 30%, that is 750 to 1500 ml of the blood loss is present. In the moderate, it is 31 to 40%, that is 1500 to 2000 ml of blood loss is present. In the severe shock, it is more than 40%, that is more than 2 liters of blood loss is present. So next, BP, urine output and GCS are normal in the class 1 and class 2 and reduced from the class 3, and blood requirement is present in the class 3 and massive transfusion is required in the class 4. So how the hemorrhagic shock patient may present? Early we can see the tachycardia, that is increased heart rate, and second it is a cold extremities, sweating, altered sensorium and reduced pulse pressure, and late features is the fall in BP. So if the patient is present with the hemorrhagic shock, first we have to control the bleeding, and next management it is the start IV line, that is replacement of the blood or the fluid. So firstly we have to look whether the patient is stable or unstable. If the patient is unstable, how to know if the patient is unstable? If his SBP is less than or equal to 90%, it indicates that at least of 30% of the blood is lost. The patient is in traumatic cardiac arrest. In this situation, if the bleeding site is known, control the bleeding and then give the IV line. If a site of bleeding is not known, go for IV line, and next it is immediate investigation, control the bleeding. And the how to know if the source of bleeding is known? In the question they will say that there will be a bleeding on the floor, that is external bleeding is present. So if the external bleeding is present, a patient is in the if patient is unstable, we have to apply the pressure, then explore, then place the IV line. Second site, it is the thorax. If thorax, if it is presence with a massive hemothorax, place the chest tube. If after placing the chest tube, if we get more than 1500 ml of the blood in the start, there is a need for chest. Only the chest tube is not required. We have to go for the other step, that is thoracotomy, and then place the IV line. And third site, it is the abdomen. In the abdomen, if it is a blunt trauma abdomen, if it is leading to peritonitis, and if it is a penetrating trauma, go for the exploratory laparotomy and then place the IV line. And the fourth site, it is a pelvis and retroperitoneum, and pelvis and retroperitoneum. So put the pelvic binder and tighten it, and place the IV line. If it is a long bone fracture, immobilize the long bone fracture and then IV line. So in the unstable patient, so this is how we manage if the site is known. If the site is not known, do the first place the IV line, then do the investigation and then control the bleeding. So how we maintain this with the IV line? In the unstable patient, we have to do the balanced or the controlled or the permissive hypotensive resuscitation. That is, we have to give the firstly the 1 liter of the RL or the NS, and then shift it to the 1:1:1 of the PRBC, FFP and the PRPs. So PRBC needs the time because in order to it should be come to the normal room temperature. So in the at the meantime, we have to start the FFPs and also the PRPs, then start the PRBC. So along with that, we have to give the crash to, that is if the patient presents to the hospital within 3 hours of the trauma, give the injection Tranexa, which is an antifibrinolytic agent. So conclusion is that if patient is unstable, if the site is source of bleeding is known, control it and place the IV line. If a source of bleeding is not known, first place the IV line, do the investigation and know the site and control it. So in the IV line of the unstable patient, we have to do the balanced hypotensive resuscitation. If a patient becomes stable, then only we have to proceed for the D. In the stable patient, we have to give the RL at the maintenance dose, then go for D directly. Next, in the IV line, so what are the requirements? The requirements are 2 wide bore cannulas need to be placed in the antecubital vein. If a cannula can't be kept in the peripheral, if it is fails, go for the intraosseous cannula, which should be placed in the proximal 1/3 of the shin of the tibia. And if it is also fails, go for the venous section and or the venous cut down. So points to be remembered is, should not place no central line should be placed, and no cannula should be placed in the great saphenous vein or the short saphenous vein. And how to know the adequacy of the resuscitation is best assessed by the urine output. If it is an adult, more than 0.5 ml per kg per hour is lost. If it is pediatrics, if it is more than 1 ml per kg per hour is lost. The best parameter for requirement of the fluid is the pulmonary capillary wedge pressure followed by the central venous pressure. The fluid of choice is the crystalloid, and the best it is the blood. So for 14 gauge cannulas, color codings are, if it is a 14 gauge, if it is orange color it is a 14 gauge, grey color it is 16 gauge, green it is 18 gauge, and pink it is 20, and blue it is 22, yellow it is of 24, and violet is 26. So most common given blood in trauma, it is blood in trauma resuscitation, it is O negative. Prefer blood for cross match. Prefer blood, it is a cross matching blood. So next thing, it is a D for the disability. So we have disability of we have to do the focused neurological examination. Second, GCS. Third, it is pupillary reaction, and fourth, it is a lateralizing sign. And next, proceed for the E, that is environmental exposure. So here we have to cover the patient with a warm blanket to prevent the hypothermia, and give the fluid at 39 degrees centigrade, and do the log rolling, that is minimum of 4 individuals are needed. If lower limb fracture is present, then 5 individuals are needed, and do the helmet removal. So helmet removal for 2 individuals are needed for the helmet removal. So this is the primary survey. So adjuvants to the primary survey are the pulse oximetry, ECG, ABG, Ral's tube. Ral's tube should be given in the oral route. Next, Foley's catheter, and 2 X-rays need to be done. One it is chest X-ray and pelvic X-ray at bedside and AP view, and E-fast should need to be done.